Hello, everyone, and welcome to another edition of the Gastroenterology Video Journal Club. Today, we're very fortunate to have Fernando Asperaz, who will be discussing a paper of his that was published in the print version of Gastroenterology in August of 2024. The title of this paper is Thoraco-Abdominal Wall Motion Guided Biofeedback Treatment of Abdominal Distension, a randomized placebo-controlled trial. For this particular session of the Journal Club, we're lucky enough to have the Temple University Gastroenterology Fellows, as well as some of their attending physicians. Today's session will be directed by Tess Peterson, who will introduce various questions after Dr. Asperaz has a chance to present his paper. So with no further ado, Dr. Asperaz, we look forward to your presentation.
Okay, thank you very much. I will share my screen. What is it? Wonderful, wonderful. I did it. So you have heard the title of the presentation, and before coming to it, let me just give you a background. Basically, we have shown that the walls of the abdomen actively and constantly adapt to its content. For instance, by eating a meal, the stomach expands, and that induces a relaxation of the diaphragm and a contraction of the anterior abdominal wall. And this combined effect produces an enlargement of the abdominal cavity with a minor increment in girth. This is a process that reverts when the stomach empties and when the content of the abdomen decreases and comes back to the initial tone of the diaphragm and the initial tone of the abdominal wall. So this is the normal abdominophrenic coordination, and we proposed for this phenomenon the term of abdominal accommodation. Basically, abdominal accommodation allows us to function daily without major changes in girth. However, some patients complain of episodes of visible abdominal distension. Hold on, I said episodes of visible distension, and this is an important precision. This is an example. This patient complains of this type of episodes, and here we have a CT scan performed when the patient is feeling well. And we ask the patient to come back to the unit when she was distended, and this is the CT scan during a distension episode. You can see that the diaphragm descends and a redistribution of abdominal contents with a protrusion of the anterior abdominal wall. We can contrast this morphological data with functional data. And we can do that by measuring the activity of the diaphragm by electromyography using interesophageal electrodes and the activity of the anterior abdominal wall with surface electrodes. And with these measurements, we demonstrated that during distension episode, the diaphragm contracts, increases the EMG activity, and the anterior wall relaxes. That means there is a change in tone of the diaphragm with an increase in tone and a decrease in the tone of the anterior wall. Using this EMG technique, we also developed a biofeedback system, and showing the patients the activity in the screen of the diaphragm and the anterior wall, they could learn to relax the diaphragm and to increase the tone of the anterior wall, and thereby to resolve this abdominophrenic dyssynergia. The importance of this proof of concept study was that it indicates that abdominophrenic dyssynergia is a conditioned somatic response, so is under the control of the cortex. This is the important part of this study, because the technique per se is very complex and is not practical. It's quite unpractical. So the aim or this background, the aim of the present study was to validate a simple biofeedback technique for treating abdominal distension. With the theory, with the hypothesis that wall motion could serve as a surrogate marker of muscular activity. So this slide shows the study design and procedures. We recruited patients with, again, important episodes of visible abdominal distension triggered by meals. We randomized the patients into biofeedback and control groups. The intervention lasted 4 weeks. During the first 3 weeks, we performed 3 sessions, either biofeedback sessions or control sessions, which was the same procedure without giving any information to the patients. And during the 4 weeks, we instructed patients in the biofeedback group to perform daily exercises or to take a placebo pill in the control group. We measured 2 outcomes. One objective outcome, which was the response to a probe meal, and we measured that just before and at the end, at the last day of the treatment. And we did that. We measured the electromyographic response of the muscles of the abdomen during ingestion of a meal. And we measured also the clinical response using daily questionnaires for 7 consecutive days before the intervention and during the last week of the intervention when the 3 sessions had been already performed. Let me give you an idea of how the biofeedback works. Using plethysmography belts, which are adaptable belts, we recorded the diameter of the chest and the abdomen, and we showed that to the patients, and we instructed them to expand the chest and at the same time contract the abdomen. That means chest up, abdomen in. This combined response produces a suction, a traction of the diaphragm, and that facilitates a relaxation of the diaphragm. Subsequently, we instructed the patients to mobilize the diaphragm. So keep in mind, since the main problem of abdominophrenic dyssynergia is a diaphragmatic blockade, this technique aims at releasing this blockade of the diaphragm and mobilizing. So we instructed the patients to mobilize the diaphragm by combining maneuvers of chest up, abdomen in, with chest down, abdomen out. And here you see chest up, abdomen in, chest down, abdomen out. Let me show you a short video with an example.
The screen shows the chest on top and the abdomen below. The instructions are expand the chest and contract the abdomen. And now chest down, abdomen out. Again, chest up, abdomen in. Chest down, abdomen out. Chest up, abdomen in. Chest down, abdomen out.
Okay, this slide shows the study flow. We randomized 42 patients. In each group, 2 patients discontinued the study and 19 were analyzed. This slide shows the response to a probe meal. Before the treatment and after the treatment, we measured the change in the activity of the internal oblique and the change in perimeter produced by a probe meal. Before, in the biofeedback group, before the treatment, patients exhibited the meal induced a relaxation of the internal oblique and a distension of the abdomen. After the treatment, both the relaxation of the oblique and the abdominal distension were prevented. However, in the placebo group, the placebo treatment did not influence neither the relaxation of the anterior oblique or the abdominal distension. This slide shows the clinical response. We measured the distension score averaged over 7 consecutive days in each subject during basal conditions and after biofeedback treatment. And you see how in the biofeedback group, the distension score significantly improved. However, in the placebo group, placebo treatment had virtually no effect. So to these patients, after having the placebo group, we disclosed the design of the study and we offered them to have biofeedback. And this is the response of the patients after biofeedback. You see, this is virtually the same as in the original biofeedback group. So we pulled all this data together for a follow-up. And here you see this initial response, pulling both groups together, and then a follow-up at 1, 3, and 6 months. And you see first that the response not only is sustained, but also it still improves a little bit. Another point, we also measured in these questionnaires other associated symptoms, which were basically abdominal pressure fullness. And you see that the associated symptoms improved during treatment and the improvement was sustained over time. So in conclusion, this work shows or indicates that abdominophrenic wall movement is an effective biofeedback signal for correcting abdominophrenic dyssynergia and abdominal distension in patients with disorders of the gut-brain interaction. Thank you very much. I am ready for your questions. Okay.
Thank you very much, Dr. Asparaz. We appreciate you joining us this morning and sharing your very interesting findings with our fellowship. So we have prepared some questions for you today to learn more about your study. So I will get us started. Our first question is, what is the pathophysiology of abdominophrenic dyssynergia?
Yeah, this is a crucial question. And I have also a very clear answer, which I don't know. However, I have some data to share. First, this is a somatic response. This is a conditioned somatic response. We don't know why the patients initially in the first place started to do this bizarre thing, but we know that there are some certain triggers that are quite constant within patients and between patients. Usually these patients wake up in the morning feeling fine, and as the day goes on, in particular by meals, they are getting these distension episodes that sometimes might last a few hours. But this resolves after overnight rest. So meals, the patients refer that is an important trigger, and we have shown that in the laboratory. So this is clear. And actually, this study, we selected patients in whom distension was triggered by meal ingestion. The other thing that is also, why the meals to produce that, this is not quite clear. There might be two factors. One is the sensations produced by meals, and this is also shown by sensations produced by other causes in these patients, usually for functional gut disorders. So visceral sensations is probably a strong trigger of distension. Another factor is beliefs. If the patient, cognitive factors, if the patient believes that a situation might give him or her distension, it works. So sensations is important, cognitive factors, and also some patients relate distension to stress, but I don't have data to support that. What is clear also is that distension is not related to intra-abdominal, to the volume of intra-abdominal content or other intraluminal factors in the gut. I don't know whether that answers.
Thank you.
your
Yeah.
question.
Perfect. I'll jump in for our next question. Thank you again for joining us. Could you go over, are there both local, such as within the GI tract, as well as central causes of abdominophrenic dyssynergia?
Well, as I said, abdominophrenic dyssynergia originates in the brain cortex. This is a somatic response, is the activity of the diaphragm in the anterior wall, and that can be modified by volition. So it's strictly under cortical control. The peripheral factors, GI factors, might serve as triggers. For instance, malingestion, abdominal, visceral symptoms, but the synergia is just purely a mechanical somatic response under the brain cortex. Let me get a bit further on that. The abdominal accommodation is a physiological reflex that is wired within the nervous system. Abdominophrenic dyssynergia overcomes this physiological reflex, and the brain takes over with this abnormal paradoxical maneuver.
Thank you.
Question. I'm Aaron, one of the GI fellows.
Sorry, the first part of your question was out. The video, the audio was out. Can you repeat it?
We can't hear you, Aaron. I'll ask your question if that's all right. All right. So Aaron's question was going to be if you could discuss the plethysmography technology, like the actual belts that were used. What are they used for? Are they available for other folks and in the other clinical applications?
Well, I can give very little details about that because I know little. This technique is used for different purposes. As I am aware that is used in the intensive care units to monitor respiration. And Peter Warburg years ago developed an ambulatory system to measure abdominal distension. And I took his idea, and I had a local company developing a custom-made system for me for this purpose. The belts are commercial, so the belts are extensible, and a change in the length of the belts produces a change that can be a change in impedance that can be transformed in an electrical change and shown on the screen. So there are commercially available equipment, but mostly focused for the use in intensive care units.
Great, thanks.
Thank you, Dr. Esperos. I'm Mohammed Ali Khan, one of the third-year GI fellows at Temple. The question I wanted to ask was just in regards to the exclusion criteria for the study. I noticed that organic diseases, having a history of them or detected on a clinical workup, people who had organic diseases were excluded. So I was wondering, does this include any kind of organic disease or specifically GI organic diseases?
Well, for this study, we ruled out any kind of organic diseases. Most of the people were middle-aged, so there was no cardiocirculatory diseases, and we wanted to have a clean population, and we ruled out. No, we did not include patients with any known organic disease. Although probably the technique would work as well in a patient with hypertension or a cardiac arrhythmia or one of these usual organic diseases at a certain age.
Hi,
Thank
I'm
you.
Lindsay. I'm one of the second-year fellows. So we know there's an overlap between psychiatric comorbidities and disorders of the gut-brain interaction. So I'm curious about your reasons for excluding patients with psychiatric disease or folks who are on psychotropic medications. And do you think this could potentially limit the practicability or generalizability to general practice?
Yeah, again, for practical purposes, in this proof of concept small study, we wanted to have a population as homogeneous as possible. And so we ruled out, we discarded patients with psychiatric or psychological comorbidities. I do not have experience in studies, but it is my intuition or some observations make me think that patients with psychiatric disorders might not respond as well. This is anecdotal observations in my own practice, but these patients might be more difficult to treat because they might have other type of beliefs or motivations for producing these distension episodes. And I'm not sure whether the technique will work as well in this type of patients. Nevertheless, the answering your question, I do not know. And it is possible that it has to be specifically studied in this population.
Great. Hi, my name's Ben. I'm one of the fellows as well. Why was a pill chosen as placebo rather than a different or unvalidated exercise?
For consistency, because we had performed a study with a biofeedback guided by electromyography, as I mentioned, and we tended to reproduce the conditions of the study as closely as possible. And in this previous study, we used a pill as placebo and wanted to do that. I also, again, this is a proof of concept study. The size is very small, and we wanted to use a placebo that really did nothing. And any kind of exercises, there is the potential that might help or might be deleterious. So we wanted to have a very clear answer about the effect of the biofeedback. And that's why we use the most neutral intervention as control.
Great, thank you.
Hi, I'm Krista. I'm one of the GI fellows. We noticed that nearly all the participants in the study were women of childbearing age. Did you notice any interaction with issues related to the menstrual cycle? And do you feel that these results are generalizable to men?
Yes, you're right. Abdominal distension is by and large much more frequent in women than in men. All the men also suffer it. Regarding this menstrual cycle, there have been some studies showing that the menstrual cycle might affect abdominal distension. And so to get rid of this confounding factor, we did both evaluation period. We measured the outcomes on the same period of the menstrual cycle. Patients were included in the first in the first phase of the cycle, and in the first of the cycle, the first evaluation was performed, and the intervention lasted 4 weeks, and the second evaluation was performed exactly in the same part of the menstrual period, in the first part. So we tried to get rid of these potential influences, which probably exist by this design. And whether in men, the experience with biofeedback men is much less because it is less frequent, but so far they seem to respond as well as women.
Thank you.
Thank you for joining us today. I'm Aditi. I'm one of the second-year GI fellows here at Temple. My question for you is that overall, it seemed like the instructions for altering the dyssynergic kinetics are pretty simple. And we were wondering if you think this technique could be reliably taught without the plethysmography belts as well to help it be more accessible.
Yeah, this is a very smart observation. Actually, we're working on that. So keep in mind the history of all this project. We started working on that about more than 20 years ago. And step by step, we were developing first the concept of the dyssynergia, and second, the potential treatments. And everything so far has been relatively complex. First, to make the concept believable, which at the beginning we were confronted with a lot of skepticism. Second, to have a technique that works. And third, to have the technique that works and also available, also that can be performed. And this is exactly where we're now. We're trying to develop, having shown this last study, we showed that using wall motion, we can teach the patient. And using wall motion opens the door for non-instrumental biofeedback techniques. And this is exactly what we're doing now. We are developing a technique, and actually we have already a technique that we are testing in a study, and we're planning a multi-center study to make sure, or to validate the technique, to demonstrate that it works. And in this moment, I believe this technique would be fairly easy and for application at any center without specific experience. I insist, keep in mind that my philosophy, and this has been my philosophy, I didn't want to sell anything, to send any message to the community that I was not certain of. This concept at the beginning was quite challenging and offered a lot of resistance. So each step we were taken, we wanted to be sure that it was we had a degree of certainty for communicating and to make it very relevant. My concern was years ago that if somebody started to do that in the wrong way, the concept would be discredited, and that would end up in harm for the patients that potentially could have been benefited if the technique would not really survive the criticism, then this would be dead. But yeah, your question is excellent, and this is exactly what is our current aim.
Thank you so much.
As a follow-up on Aditi's question, how do you suggest incorporating these exercises into patient care? And do you think it's appropriate to start incorporating into patient care now, given that it's the exercise is very low risk?
It's a matter of philosophy. And these are the low-risk exercises, but if they don't work, then the people will believe that it is useless and it might not be used. So what we pretend is to have a system that has been validated and then offer it to the community with assurance that whoever does it in the right way, if we're able to provide specific details on how to do it, if they follow the instructions, the technique will work. This is the reason. Although how to include that, which was I interpret the first part of the question, how to include that in the routine? Well, patients with abdominal distension usually have a functional gut disorder, and I've already discussed that the visceral symptoms, abdominal symptoms, might serve as trigger of the distension. So the first thing that I do myself with these patients is to treat the functional gut disorder by the treatment you use anyway. Second, to use these some things to be something very important is constipation. I recommend to be proactive in looking for constipation, because patients with distension and constipation, if you do not get rid of the constipation, distension will not be resolved. So ask the patient directly, and if there is any doubt or any hint, go for an anorectal manometry, do a anorectal feedback, because if you solve the constipation, a lot of patients the distension will be also solved. Okay, so this is one part. The other part, dietary advices like low diets, prebiotics, probiotic, that has an effect, does not cure, but does a contribution. And if you can identify any trigger factor, then act upon it. And if everything fails, then go for the biofeedback would be an option. But first, I will go through the usual steps that we use with this patient with functional gut disorders.
Thank you.
So could you go through, is bloating a different symptom as opposed to abdominal distension? And if so, could you consider using biofeedback for patients with bloating?
Boy, I love this question. Yeah, you're absolutely right. First, bloating is equivocal. What do you mean by bloating? Keep in mind first that in various languages, there is no word for bloating. So each time you see a foreigner talking about bloating, probably he's talking about different things, what you mean, have in mind. Second, even within English-speaking population, people, both patients and physicians, use bloating for different concepts. So when you read the literature, be aware that bloating is very equivocal, and in different papers, the meaning of bloating might be completely different. It has been suggested, and I completely agree, not to use the term bloating or use the term bloating sensation, referring to the sensation of abdominal pressure fullness. Okay? So bloating is a different thing from distension. Bloating is a visceral sensation, is absolutely unspecific, does not mean anything special in terms of pathophysiology, is usually associated to other symptoms like borborygmy, abdominal discomfort, flatulence, etc. All these symptoms have the same pathophysiology. Usually, the most important factor is the hypersensitivity of the gut. It has been, the studies looking about intestinal or gut content have not been able to show differences, and I've done a lot of these studies which were negative. So the pathophysiology is the same for all those symptoms. Bloating does not require any specific test than other symptoms, like flatulence, for instance, of abdominal or abdominal discomfort, and the treatment is the same. So this goes for bloating. As for abdominal distension, be sure that you talk about visible distension and produced by episodes. And if a patient tells you or refers episodes of visible distension, you can be pretty sure that the patient has abdominophrenic dyssynergia, and you can treat it accordingly. Be careful with patients that refer continuous distension, unremitting distension, because most of them are just overweight or fat or with a fatty abdomen, or they believe they have a distension that you cannot substantiate. This young person that has a quite flat abdomen but is convinced that the abdomen is absolutely distended. This is a case which is difficult to manage.
Thank you.
Hold on, no. There is a part in your question. Whether bloating might improve by biofeedback treatment, I don't know. There are two series of data. I have two series of data. One showing that when bloating sensation or associated symptoms go together with distension, if you improve distension, they also improve, and I showed that in the follow-up slide. But on the other hand, if you treat patients with bloating sensation without distension with biofeedback, we're running a study, and the preliminary data show that they might not improve. These are not final data, but the impression so far is that bloating sensation without visible distension might not improve with biofeedback treatment. Again, preliminary data.
Great, thank you. I'm Aaron, one of the third-year GI fellows. In addition to evaluation for celiac disease, did pre-treatment clinical workup involve exclusion of other processes like SIBO, lactose intolerance, or H. pylori infection?
No, but this is my personal view. Actually, no. To be honest, we left the physician in charge to do her own routine. Myself, I do not believe that SIBO plays any role at all in IBS, but it's a personal view. And the same goes for lactose intolerance. If these situations concur with visceral hypersensitivity, then might have a contribution. But per se, I do not believe that SIBO, defined as really bacterial overgrowth, and a lactose intolerance produce symptoms per se, if not associated with other factors, principally visceral hypersensitivity.
Thank you.
Thank you. And I had a question regarding the demographics of both the placebo and the experimental cohorts. How would you describe the racial and ethnic makeup of them, and where these cohorts matched in regards to the demographics?
Well, the population we get referred as are white Spanish population. There is, in these studies, we did not get racial interference. This was quite homogeneous because in the population we get referred. It's not the same as in other areas where that might be a mixture of different ethnicities.
All right, so I think I have the last question of the morning. Thank you again for spending your time with us. We were curious about those reproducible offending meals. Did you notice any trends among different participants in what made up those meals?
Well, a lot of patients refer, the group that is most referred as offending is, veggie salad fiber. This is the group that is most quoted. Then bread cereals, legumes, fatty meals. These are the most frequent ones. And but again, all these meals produce the effect quite immediately. So it would be highly unlikely, or there is no way to think that for instance, these fiber meals might be fermented, and the fermentation process with the gas release might produce the distension, because the effect is usually quite immediate. So I believe, but this is just an impression, that is mostly either that the meals produce symptoms. For instance, fatty meals in dyspeptics might produce symptoms, and the symptoms might produce a distension, might trigger the distension, or cognitive factors. Patients that believe that one meal is an offending meal, and that will be reproduced.
Thank you.
So those are the conclusions of our questions. Again, thank you so much for spending your time with us this morning and educating us about your fascinating study. We appreciate your time.
Well, thank you for your attention. It has been a pleasure sharing the part of the morning with you. And again, thank you very much.
All right. Well, thank you so much, Professor Asperos, and thank you also, of course, to the whole Temple team. The recording will be put on the web along with the now growing library of similar efforts. So thank you all for participating.
Okay, wonderful, wonderful.
All right. Thank you so much.
Thank you very much. It's been very entertaining.
All right. Bye-bye, everybody.
Bye-bye, everybody.